not believe it. And then I found out later on from some people that still work with him that he's on Instagram.
So that is like a maintenance for their actors.
Yes, they'll be on something PO, actors, and make them blues. A bluish purple tint.
I didn't see in the dark. Like, when are we gonna get to like a regular, and all that stuff?
Say that
Like
again?
irregularly, regular. That's
We're not gonna talk about that right now, so you don't have to worry about it.
okay.
You only have to worry about what I tell you. Because again, you're gonna get a lot more EKG stuff in 211, so we try not to overlap too much. Give y'all too much now. All right. Okay, and then there's Lanoxin or digoxin. You may still see some. Again, it's not the first-line drug anymore, but it is still a good drug. You just have to worry about dig toxicity, which is a real thing. So if someone is on digoxin, we're going to be checking their labs, their dig levels, periodically, to make sure that they're not getting too much in their system. It can be a slow IV infusion or a slow IV push. Typically, you're going to see it more as an infusion. If they start getting toxic, they may complain of a lot of nausea and vomiting, seeing a yellow halo. These are important things for y'all to know. Their vision may have a yellow tint to it. And it is very important that we know what their potassium and mag levels are before we give them dig, because they take up on the same receptor sites in the body, the digoxin and the potassium and magnesium. So if the potassium or the mag levels are low, more of that digoxin can take up on that receptor, which can make the patient toxic, because they have more of that free drug floating around in their system, okay? Because the body absorbs it a little bit more because of the low potassium and magnesium. So make sure that y'all know what the potassium and mag is before you ever did that. I have seen a digitoxic patient one time when I worked in CVICU, and she was totally fine, but of course she had heart surgery, so she was on a ventilator, so she couldn't really tell us, oh, I might be seeing yellow or blah, 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 whatever. But with no warning at all, her heart rate just fell out. Like, she went super bradycardic, like in the 20s. And thank goodness we had her pacing wire still, because she had had heart surgery and we were able to pace her. But usually you have a little bit of a warning, like their heart rate will kind of slowly start getting slower, or they'll have signs and symptoms that they can tell you about. She was not, and that was the only digitoxic patient I've ever actually seen, because we monitor them so closely with their labs and stuff. Don't know how hers was picked up. Okay, so this is what a TEE looks like. Where it just goes down the esophagus and you're just right behind the heart, and the picture is beautiful. You can see, other than something invasive like a heart cath, this is a great picture. And then this is when they have it like a transthoracic, where they're just putting the electrode on the outside and taking pictures of the heart, outside of the body. But if we are concerned about clots, this is what we're gonna do, a TEE. Okay, I think I've heard, oh, we do need to know, make sure that you've got your patient in PO if they're going for a TEE. We do that for most procedures, but just make sure that they're in PO, and because we will numb their throat and everything because we're putting something down their throat. We need to make sure that their gag reflex is back before you feed them. That's really important. Uh-huh.
So would it be more or less like if we see AFib and we're sure it's that or A-flood, we would automatically put on inhale?
Well, not necessarily, no, but, I mean, you're gonna have protocols, you're gonna contact the provider, you're gonna have orders, yes. If they're, symptomatic or they're unstable, then there's gonna be protocols that you follow. All right, this is what electrical cardioversion looks like. It's synchronized cardioversion is what I'm talking about. When they have a pulse for AFib, A-flutter, SVT, VTAC with a pulse. And you're gonna, again, place these pads just like this, but thankfully there's pictures on the pads. So if you're frantic, you can just look at the picture and it'll tell you. Some nurses still get it wrong because they're still frantically frantic and they can't read the picture. They can't look at it. It's gonna be a much lower energy level, usually gonna start at 50 or 100, especially now because all of these defibrillators are biphasic and it requires a lot less energy. Biphasic means as you deliver the energy, it kind of goes through and then bounces back up, and it's a lot more successful with getting people out of rhythms than the old kind that we used to have. If you have time, if it's not a true emergency, if you have time, please sedate these patients, because that hurts really bad. Even the ones that are so sedated they're barely breathing, they come up fighting when you hit that cardioversion button. So, again, please make sure you sedate them if you have time to. All right, so this is what it looks like. This is what I was talking about, the little doop, 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 doop. And it counts it just like that. That's exactly what it sounds like. And then you deliver the shock and this goes away. So if you're gonna do another synchronized cardioversion, please put the cardioversion, the sync button back on. I thank the Lord it did not land on the T-wave, but I synchronized cardioverted a patient several times when I worked in the cath lab, and we were gonna do it one more time, and I forgot to push the sync button. And right as I was pushing the defibrillate, the charge button, Dr. Ryan said, "Did you push the sync?" But I'd already pushed it. But thank the Lord, it did not land on the T-wave, or we would have had a VFib or VTAC problem. I'll never forget that. That's what happens when you get complacent. We had been like, several times, and then anyway, so things can happen. Just try very hard to not let them happen. We all have, anybody that's been a nurse for a while has stories where they've messed up. All right. Okay, and another thing that you may see with someone that's in chronic AFib or A-flutter, you may see the Watchman procedure. It's where they go up through the groin. It would look like a cardiac cath, except they're going into the venous system instead of the arterial system. And they go all the way up into the atrial appendage, and they employ this device. It's called the Watchman device. And it sits in there and kind of grows in and blocks off that area so that you don't get clots. And the goal for this is so the patient can come off anticoagulation therapy. So they may still be in like AFib or A-flutter, but that's gonna prevent them from having clots. And that's what it looks like. They will still be on anticoagulation therapy until it grows in good, until it gets good and epithelialized. And then they can slowly start coming off of all the stuff. Okay, let's do a review. Does anybody need a break? Y'all wanna take a quick break? Okay. Y'all just wanna keep on keeping on, don't you? Okay, so let's name this EKG strip. All right, so what is this EKG strip? Just look at all the things, don't guess. Look at do you see any P waves? Not really. You see a T wave though. You see what? A QRS. This is a 6-second strip. How fast is this? Woohoo, it's really fast. 19. So yes, it is SVT. How do you know that? Anything greater than 150, it is regular. There are P waves, you just can't see them because it's so fast they just kind of melt into the T wave. But if you slow this down, you'd be able to see that there's P waves. And it is very regular. Alright, what's this one? Look at the T, look at the QRS, look at the T, all the things. Yes. Does this look normal here? The peer interval? QRS, it actually looks a little long, but we're not talking about blocks yet. So yes. QRS, the ST segment, where's that ST segment? Right there, right on the isoelectric line. The T wave is upright and rounded. It's just what? It's slow. So let's see, 1, 2, 3, 4, 5. 50 beats a minute. Yep, so it's 50, so that makes it what? Sinus bradycardia. Know this immediately. So AFib. Okay, so how do we know? What's all the things that makes this AFib? Chaotic. No recognizable P waves really. It's irregular. Let's see. 1, 2, 3, 4, 5, 6, 7, 8, 9. Did we really count that now? But it doesn't look like it's a rapid ventricular response though. But how would we know for sure? Listen or count for a full minute. Alright, what's this one? Let's look at everything. The P, yeah, it's kind of roaming. This patient's moving around. But yeah, it is on the isoelectric line. I can just tell it's a roaming isoelectric line because that usually means the patient is moving around. But it is. Okay, so PR interval, does that look pretty good? Yep, it does. It's less than 0.2. The P wave is what? Upright and rounded, and it's before every QRS, yes. And then you have the ST segment. If it wasn't a wandering isoelectric line, it would be on it's not sagging down. And then there's a T. And then there's a T wave. So it's got all the components that we want it to have, right? The QRS is nice and narrow. The PR interval is less than 0.2. And then you've got your upright T. So what's the rate of this one? Okay, so what is this gonna be? It's sinus rhythm, but barely sinus rhythm. All right, what's this one? Remember to do all your things. know that gets exhausting. P's, P's. Okay, do the P's look normal?
Yeah.
All right. Do the QRSs look normal? What about the T? Yeah, it does. The ST segments on that isoelectric line. So it is a 6-second strip. Remember, I said it, that's all you'd ever get, from me anyway. Yeah, so you count, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So 130. So that is definitely still fine and fast. All right, what's this one? It is a flutter. What makes it a flutter? It is regular. And what do you see here? The sawtooth. What are these called? Flutter waves, right? And how fast is it? Okay, so is this an RVR? A flutter with RVR? No, it's just a flutter. All right, y'all have any questions?